Good morning and welcome everyone to our second Primary Care Snapshot Workgroup meeting. I'm Debbie Lindis, Healthcare Delivery System Group Manager at the Office of Healthcare Affordability, or OCA, which is housed within the Department of Healthcare Access and Information, or HCAI. I use she, her pronouns. And during today's meeting, which will last for 1 hour instead of our usual 90 minutes, we'll start with a brief reminder of meeting logistics, and after that, we'll present an overview of OCA's primary care definition and review feedback we've received so far on the snapshot. Next, we'll discuss the proposed workgroup charter. And before we dive into our discussion of potential primary care investment indicators, we'll review a proposed approach for evaluating the indicators. And we'll end with a brief review of future workgroup meetings and next steps. As a very quick reminder, here are our workgroup members and the range of stakeholder perspectives they represent. And I'll just briefly recap our meeting format. This is a public meeting, and we appreciate and consider the thoughtful comments from all attendees. Workgroup members may offer verbal feedback or make comments in the chat, and non-workgroup members can offer input through the chat or provide written feedback to the OCA team after the meeting. We do request that all commenters provide your name and organizational affiliation with your comments, and we may not be able to respond to all comments during the meeting, but we'll review all the chats and use them to inform our work moving forward. And as a friendly reminder, these are some of the etiquette tips that can facilitate our collaboration during these meetings. So first on our agenda is OCA's primary care definition, which was developed by OCA with input from its investment and payment workgroup and numerous other stakeholders, and which is used for the statewide primary care investment benchmark. As we reviewed at our last meeting, this is the vision for primary care delivery in California that guides our efforts. OCA and the Investment and Payment Workgroup kept this vision in mind when we defined primary care. With that vision for primary care delivery in California as our guide, we identified the types of primary care providers, places of service, and services that count towards measurement of primary care spending. OCA also reviewed 18 state and national primary care definitions to inform which codes to include in the OCA definition. And we discussed principles and key decisions for claims and non-claims payments with a range of stakeholders. Further refinements to the definition were made based on feedback received through the public comment process. So the OCA primary care definition includes a code set with a list of primary care provider taxonomies, places of service, and service codes to identify primary care claims and capitation encounters. The definition also includes all primary care and behavioral health integration payments and primary care capitation payments. To capture the full range of primary care payments, the definition includes allocation methodologies for non-claims payments like those for population health and infrastructure, performance incentives, shared savings, and other types of capitation such as professional and global capitation. Our goal is to leverage the OCA primary care definition for the snapshot indicators where possible, but we recognize that it may not be feasible to apply the definition to every indicator to the same extent, as the granularity or methodology of data collected may vary. And next, I'll review some feedback we've received to date on the snapshot from this workgroup, the OCA Investment and Payment Workgroup, and the OCA Board. We anticipate additional feedback later today and next week as we introduce the snapshot to both the OCA and the Healthcare Payments Data Program Advisory Committees. So to start off, this is a high-level summary of the feedback you all provided at the November Snapshot Workgroup meeting. And I'll first note here that HCAI may not be able to answer all stakeholder interests via the snapshot, but we will maintain a list of desired analyses for both future iterations of the snapshot and for ad hoc research opportunities within and outside of HCAI. So in November, we heard appreciation for the Massachusetts primary care dashboard and interest in California indicators on non-physician practitioner workforce, continuity, geographic variation, and underserved areas. And we also heard interest in understanding how provider organizations pay and support primary care providers, differences in performance based on type of practice ownership. For example, looking at differences in performance between a primary care practice that's owned by a hospital versus owned by a physician. Measurement of team-based primary care delivery and non-billable services. And I'll note here that OCA's primary care definition includes provider taxonomies for clinical members of the primary care team, some of whom, such as nurses and community health workers, cannot bill for services under current guidelines. OCA's non-claims payment allocation methodologies seek to include payments for services that are not typically billable, such as certain care coordination services for primary care programs or population health management services included in capitation payments. And we also heard interest from the work group in learning more about the Massachusetts process of defining primary care and stakeholder reactions to their definition. This slide summarizes feedback from the OCA board and the investment and payment work group. So from these stakeholders, we heard interest in indicators that measure patient-provider relationships and continuity, performance across and within markets, geographic variation and variation across populations, like for children versus adults, quality of care for underserved populations, and the practicing primary care workforce, both physician and non-physician, including looking at the pipeline through and beyond residency to understand primary care delivery system capacity. Outside of indicators, stakeholders expressed interest in understanding primary care provider reimbursement relative to specialists, barriers to improving primary care investment and delivery, and differences in performance based on primary care practice maturity. There was also interest in relationships between primary care policy initiatives and performance in each of the domains. And again, while these topics may not be ones the snapshot is focused on addressing in the near term, we will keep a running list of these interests and come back to them as we develop future iterations of the snapshot. And for our next agenda item, I will pass it to Miranda Wirtz, our senior primary care specialist at OCA, to review and provide an opportunity to discuss the proposed workgroup charter.
Great. Thanks, Debbie, and good morning, workgroup members. To set us up for the discussion, I will review some key aspects of the charter, including the objectives here, workgroup member roles and responsibilities, and workgroup activities in the next few slides. The purpose of the charter is to provide clarity on workgroup objectives and activities and define the roles of workgroup members, HCAI, and consultant staff. The aim of this workgroup is to offer a transparent public forum to understand stakeholders' priorities for the primary care snapshot. We hope to have thoughtful, comprehensive, and balanced stakeholder engagement to ensure strong buy-in and build a smooth on-ramp for implementation. Additionally, we are looking for expert technical input on the availability and feasibility of primary care indicators to include in the snapshot. As workgroup members, we look to you all to support the development of the primary care snapshot. This includes active participation in meetings, preparing ahead of time when you're able, contributing expertise, insights, and ideas, as well as sharing perspectives of your organization and stakeholder group, and when requested, soliciting feedback from colleagues within your organization and across the state. Workgroup activities include reviewing best practices and lessons learned from other states and previous work in California, as well as from academic literature on primary care measurement and reporting. Additionally, the workgroup will inform the development of primary care indicators for the snapshot that promote the vision for primary care and engage stakeholders to gain the benefit of their knowledge and experience. We will also discuss strategies to motivate collective action towards high-quality, sustainable primary care in California through the information included in the snapshot. I'll also note that the work group will not develop any formal recommendations or make any final decisions about snapshot content. With that, I'll pause here for any questions or feedback from workgroup members on the workgroup charter. Okay, well, this isn't the only opportunity to provide feedback. If you have any as you review the document of the charter that I sent out the other day, please feel free to email me at the email on the slide here with any feedback by Wednesday, January 28th. And then we will finalize the charter at the workgroup meeting scheduled for March 11th. Okay. So next, I will discuss our approach to evaluating primary care indicators. As a reminder, the purpose of the primary care snapshot is several-fold. First, it will create a shared understanding of the health of California's primary care sector for an audience of engaged stakeholders such as purchasers, payers, providers, state government and other policymakers, consumer advocates, and researchers. Second, it will track system-wide progress toward equitable, high-quality, and sustainable primary care for all Californians. Third, it will compile and report on data coming from across HCAI and also from other sources to understand the state of primary care in California. We'll use a phased approach, moving from a static report to interactive dashboards with accompanying reports and adding indicators of interest to stakeholders over time. Finally, the snapshot will monitor performance on key elements of the health of primary care in California, including spending and outcomes, and will help identify gaps and challenges to motivate action in the domains of investment, workforce, access, quality, and equity. The primary care snapshot will include data from several existing sources, incorporating both existing and new analyses from California and national primary care data sources. HCAI will work with departments across the state, national subject matter experts, and this work group to align methodologies for analyses with state and national best practices when possible. We will also update reporting to align with OCA's primary care definition when possible. I'd like to note that new data collection is not a part of the primary care snapshot initiative. So these are the criteria we propose to evaluate whether an indicator is the right fit for the primary care snapshot. The first is whether the indicator is of interest to California stakeholders and whether the indicator is actionable for them, meaning is there action stakeholders can take based on the indicator results. The second criterion is whether the indicator can be developed using existing and accessible California or national data sources that can be tracked over time. This is crucial since HCAI will not be collecting new data for the snapshot. The third is if the indicator directly measures the strength of the primary care sector. This is especially important since there are many indicators that are related to or impacted by primary care, but do not provide any direct insight into the strength of primary care. The final criterion is whether the indicator can track change in the primary care sector within the 5 domains. After reviewing indicators at each meeting, we will ask workgroup members to take a brief survey to help us determine whether each indicator meets all of these criteria listed here. So I'll now open it up for questions and feedback from workgroup members on the primary care snapshot purpose, approach, analyses, and criteria that we've proposed for evaluating indicators.
I have a quick question. This is Dr. Ayala. Good morning. For these particular criterias, is there background definitions or background information that we can review, or maybe there's I know there was initial documents sent out, but are there any further educational pieces that we need, or?
Yeah, that's a good question. Did you mean like how are we defining, say, like
Right.
actionable or strength of the primary care, like those? We can
Yeah.
definitely build out more materials so that we can all kind of be aligned on what exactly these criteria mean as you all are evaluating them as well. So we haven't set any materials like that yet, but that's definitely one that we can develop. So that's a great suggestion.
Thank you.
Yeah, Carlina.
I'm curious, since the primary care investment is a sort of separate but related and much larger work stream, if you can speak to sort of the reporting on that as it relates to this, and sort of how you see them syncing up with one another, since this is sort of more of a parsimonious set of measures and that is a much more extensive effort.
Yeah, I see Debbie came off mute, so Debbie, go ahead.
Yeah, I'm happy to speak to that. Thanks, Carlina, for a great question. So we envision the snapshot using a subset of the reporting that we will also report in the HCAI's OCA reports, OCA's annual reports on primary care investment. So there'll be more detail, specifically probably more emphasis on plan performance in the OCA primary care investment reports, where we're measuring performance by plan against our investment benchmarks, whereas the indicators we'll discuss just a little bit later are more of a high level kind of system-wide approach, but using the same data that we're collecting for OCA. I don't know if that answers your question, Carlina. Happy to further discuss.
That's great. Thank you, Debbie.
Thank you.
Yeah, Jeremy, go ahead.
Good morning. Obviously these are very kind of broad indicators, things like workforce, access. At what point do we kind of drill down and talk about what subsections of each of those indicators we're talking about, right? Like within workforce, are we going to just have some questions? Like, are we going to talk about burnout and clinician, well-being in the workforce? If we're talking about access, are we talking about productivity? Are we just talking about length of appointment, like they're next available? What's the plan for that kind of those discussions? Or is now the time?
Yeah, we will start our discussion today, so we'll get into some investment indicators, and then the plan moving forward would be to drill down into one or two domains, into specific indicators at all the upcoming meetings. So we'll want to cover all these domains before September, probably, so that we can make sure that we have a strong set of indicators going into preparing the static report for this fall. So we'll do exactly as you said at every meeting, getting into the weeds, discussing indicators in each domain.
Great, thank you.
Yeah, Ed.
Hi, good morning. Thank you for sharing this. My question is, at some point, do we intend to also include in the snapshot the adequacy of the primary care network as a broader entity? For example, would something like how the HPI index identifies hot and cold spots when it comes to the metrics that the HPI index is measuring, is that something that could be part of the criteria as we evaluate what the strength of primary care looks like? And I only ask because some areas might have a primary care, well, everyone is experiencing a primary care shortage, but generally understanding what that density looks like to help inform, especially the third, I guess, bullet there, which is to measure the strength of primary care.
Yeah, I think the answer to your question is yes. Debbie and anyone else, feel free to chime in. I know that we are thinking of how we can incorporate the Healthy Places Index into some of these measures, especially in terms of the primary care workforce density in different regions. Debbie, do you have anything to add to that?
I think you covered it, but yes, for example, in our access domain, which we won't discuss today, but we'll discuss in a future meeting, we aim to propose a PCP density measure, and that could be stratified by Healthy Places Index scores regionally to get down to some regional granularity and geographic equity considerations.
Yeah, thanks for all of those questions. Those are all great flags, and we will definitely take note of them as we prepare for the next meeting. Are there any other questions before I move on to the next section? Okay. So now we will kick off our evaluation of potential indicators for the primary care snapshot. As a reminder, these are the domains the snapshot will focus on, and as I mentioned, we will focus on discussing potential indicators in the investment domain today. So we are proposing 3 investment indicators for the snapshot, and we'll review 2 examples of reported indicators in the next few slides to provide additional context. So the first indicator on the left of this table is primary care investment as both a percent of total medical expense and on a per member per year basis. The second is change in primary care investment from 2023 to 2024. And the third is primary care investment by claims and non-claims payment categories. All these indicators will use data collected by OCA to evaluate progress toward its primary care investment benchmark. To get the most out of these indicators, we propose stratifying the data by payment categories, such as primary care paid via claims or specific non-claims categories, such as incentive payments or capitation, and by market, payer, and or product type. So in our initial evaluation against the indicator criteria, which you'll see on the top with the same icons, we feel these indicators support stakeholder interest in increased investment in primary care, which is expected to result in improved primary care delivery and outcomes. For the second criterion, OCA currently has access to 2023 and 2024 primary care investment data for California and will continue to collect new data annually. These indicators directly measure primary care spending through claims and non-claims payments. And for the final criterion, these indicators will track changes in primary care investment in California, as well as shifts in distribution of investment across claims and non-claims payment categories over time. As mentioned previously, workgroup members will have the opportunity to provide asynchronous input on these indicators through a post-meeting survey that we will send. So that survey will collect feedback on whether the indicators included on this slide meet the criteria based on your evaluation for inclusion in the primary care snapshot. So to give some examples of previous reporting, here this slide focuses on the first potential investment indicator, which is the primary care investment, both as a % of total medical expense and on a per member per year basis. We include an example here of early reports on primary care investment as a % of total medical expense from the California Healthcare Foundation to show what a visualization of this indicator could look like. The graphic shows commercial adjusted primary care spending % by health plan product in 2021. So HCAI could create similar figures for the snapshot. This slide focuses on the third potential indicator from the earlier table, the primary care investment by claims and non-claims payment categories. The example on this slide comes from Delaware's reporting on this indicator. The figure shows primary care investment by claims and non-claims from 2022 to 2023 by population, and stratified by commercial fully insured members versus commercial members attributed to providers in care transformation initiatives. This graphic shows how, regardless of the population, growth in primary care investment from 2022 to 2023 in Delaware was driven by non-claims payments to support transformation of care. Okay. We will now open for discussion and would appreciate any questions or feedback you have on the proposed primary care investment indicators for the snapshot. We are also interested in learning about any other key primary care investment indicators members think may be a good fit for the snapshot. And I can go back to any slides as well, if that would be useful. Yeah, Ed, go ahead.
Hi, thanks so much for sharing. I was just wondering, in the earlier slide, in the stratification of primary care, is the intention to align sort of how DHCS views the category of aids and category of services as kind of the aggregate view of what's projected out as the aggregate sort of indicator? And I only ask because I know for health plans, for example, consistency with how DHCS views this type of spend might allow for better alignment.
Yeah. Debbie, I don't know if you want to chime in on any of that. And Mary Jo, I know FHC worked on this visualization as well, if you want to talk about some of the process for creating this.
Sure, this is Vinayak Sinha, Senior Consultant at Friedman Healthcare. Couple notes on that. I think for this visual in particular, this is coming out of Delaware. Our team did support the state in collecting, analyzing, and reporting on this data. The data here in particular is actually aggregating the non-claims spend. So what you're seeing is primary care non-fee-for-service spend here is an aggregate of a number of discrete non-claims payment categories, such as incentive payments, potentially capitation payments, care management fees, etc. And in OCA's methodology, OCA's non-claims payments framework, the expanded framework, collects granular data on primary care non-claims payments as well. That data is the data that is going to be used to produce these graphics as well. And as currently discussed, will be reported at a non-claims category level. So currently envisioned to include the sum of primary care non-claims that are related to population health and infrastructure payments, performance incentive payments, shared savings payments, and capitation payments. So that's how we would envision what on this slide looks like that lighter blue, likely to be broken up as we think about primary care non-claim spend in California.
And Edward, I'll just jump in to kind of the broader work that OCA, the Office of Healthcare Affordability, is doing with DHCS on the primary care spending, data collection, and investment benchmark. So we worked closely with DHCS and other sibling state departments like Covered California and CalPERS to develop the definition of primary care spending and to set the primary care investment benchmark. And we are also coordinating closely with DHCS on how we collect data from Medi-Cal managed care plans to monitor primary care investment by Medi-Cal managed care plans. And we would be happy to direct you, and I think there may be a link on a slide to the methodology in more detail, and then our detailed data submission guide for submitters, if that would be helpful. And if there are any specific questions you have about funding streams and how we capture those for Medi-Cal managed care plans, we can definitely work with you to answer those questions as well.
Thanks, Margaret. Dr. Ayala.
Yeah, I just as we reviewed the prior slide, one thing that came to mind was just a question around the stratification and the consideration for geography, whether it's, I know we had mentioned in the previous reports at our last meeting around zip codes or counties. When we think of a visual, whether that's urban versus rural or zip code or et cetera, just thinking about further stratification or the potential of having that be available to see that panoramic view of what's there.
Thank you for that input. I think for investment, and others please add or correct me if I'm wrong, but for investment, our data is based on plans and not on counties. So I think we would have a hard time reporting investment at that kind of geographic granularity level, although many of the other indicators will be more amenable to more granular geographic analysis.
Okay. Thank you.
Yeah, thank you. Carlina.
Yeah, I'm curious, given conversations that have sort of been in the ether, whether or not in the primary care investment conversations there was any talk of provider attestation, of having kind of the payment getting to the provider level versus sort of getting stuck in the pipeline of the stream of payment from where it originates.
Sure, Carlina, I can jump in. So that is having a method of collecting provider attestation that they're receiving this increased primary care investment, or hopefully increased primary care investment. That is not something we discussed in detail or have pursued at OCA. We did discuss a lot about how to make sure that primary care investment from the plan to provider organizations actually gets to primary care providers or primary care practices. I think that's something we can continue to pursue at OCA, about how to better understand the flow of spending and making sure it gets to frontline primary care providers and practices. And if folks have suggestions like provider attestation or other ways that we might be able to dig into that's something at OCA we could look into.
Thanks, Margareta, for that. Yeah, Jeremy.
It's a bit of a long shot, but there's a significant trend towards concierge medicine, and there's a lot of investment going in, and that's coming from patients primarily. And I feel like it's I don't know how much data there are, and of course, we're not collecting new data, so that might make it difficult. But it would be worth just, I think, a quick peek to see if there is any good information on those trends. I do feel that concierge medicine is growing because of a strained primary care system, and so I think it does apply to the overall health of primary care. So just wanted to put that out there.
Yeah, that's a really interesting fact, Jeremy. Thanks for that. Yeah, since we're not collecting new data, but if anybody knows of any data sources, we can definitely explore incorporating those and kind of just seeing what's going on there.
There's just really briefly, there's Johns Hopkins has some numbers on it going back to 21 to 23. I don't know how much of it's California specific or anything, but it's being looked at. So whatever analysts can just kind of see what real data sources there are. I think it would be. Unfortunately, I can't give you a good source, but they may exist.
Yeah, we can definitely take a look into that. Dr. Bravo.
Yes, just curious here, looking at this, where do vaccination costs, billing for vaccination, I mean, so much of, especially pediatric primary care, involves the acquisition, delivery of vaccines. I mean, it is probably one of the foundations of primary care. How is that captured anywhere here in terms of investment, especially in the context of what may happen in the next 3 years with VFC?
Yeah, I can. That's a great question. And our primary care definition does include the cost of administering vaccinations of all kinds for all ages. So we do capture vaccine administration in primary care settings. And we also have a specific methodology that we're adding in our 2026 data collection approach to capture specific codes related to VFC vaccines for children program. So we aim to capture vaccine administration across all markets and programs.
Thank you.
Yeah, Kevin.
Hi there. I missed the first meeting, so for those whom I haven't met before, I'm Kevin Grumback. I'm a family physician at University of California, San Francisco. So appreciate really stimulating, thoughtful conversation. I have maybe just a couple of broad thoughts. Having been thinking about this a lot myself, been very involved in a lot of this work. So first is this whole notion of snapshot versus a much more intensive evaluation of primary care spending programs. I think there's a tension there, right? And thinking about the questions and all the things that come to mind. Snapshots, in my mind, are intended to be fairly high level view. Miranda, you talk about you're sort of thinking about using existing secondary data rather than collecting primary care data. So I think this is something we're going to have to continue to struggle with, right? Is you're looking at claims, so it's hard to go collect primary care data on direct consumer spending for concierge medicine. There's certainly secondary data on claims-based stuff or non-claims from health plans. We'll talk about other, I'm sure, domains such as patient aspects, whether they're quality measures or things like continuity of care you can measure by claims. I think what people have brought up, I think the hardest component to get a handle on is what's actually happening at the practice level. And I think there is a lot of interest and a bit of concern that if plans are reporting, yeah, we're spending more money consistent with the OCA benchmark target, how much of that is really getting to frontline practices because of our whole multi-tiered level of funds flow in California with delegated plans, large health systems. So I think that's going to be a tough one. And I think this is a question partly that comes back to HCAI. Is that part of the Snapshot project, or is that really, we're talking about a much more labor-intensive, data-intensive effort to do an evaluation of the primary care investment policy? So I think we're going to have to keep kind of deciding what's our domain, what's our sphere as a snapshot, kind of a snapshot project for the state, and is there a whole nother level of evaluation that needs to be going on to get at some of these things that are not so easily captured through existing data? So I just want to put a pin on that. There's a group of us that have been thinking a lot about evaluating primary care spending policies, because certainly in other states that has been one of the concerns, is people have say, yeah, we're meeting the state spending indicators, but at the front line, people are not feeling that the resources have increased tremendously, or patient experience necessarily has changed tremendously from better primary care. So we've been thinking about that. Many of you are part of the Primary Care Investment Network, sponsored by Millbank and Primary Care Development Corporation. We are on February 6th holding a whole session that's going to share a model that a bunch of people working in primary care policy and research have developed to think about more systematic evaluations of primary care spending policies. So I would definitely tune into that. If people want more information who are not part of that network, maybe I'll put my email in chat and you can shoot me an email and I can forward you the calendar invitation for that. So that's a bit long-winded, but I think we're going to have to keep thinking about where do we sort of set some boundaries about what we can do for the Snapshot project, and where do we then need to think about what HCAI and OCA might need to take on in terms of an evaluation rather than a snapshot sort of tracking of broad parameters.
Thank you, Kevin. That's very helpful food for thought for future initiatives. I think, Susan, are you next?
Yeah, I think so. Thanks so much. I think in follow-up actually with Kevin's comments, but also back to maybe one of the first work group members who mentioned this need for more of a common base from which to work of information for the work group members, because I think that we all you have such a diverse representation, which is amazing for this work group, but we all have access to different data. We see data in different ways. And I think in terms of not, bounding it in these discussions, these meetings within what it is that we can actually work with would be really helpful. So for example, these decisions about, is this the right investment indicator? To me, I'm sitting here sort of struggling, and maybe it's just me. But, I think I'm sitting here struggling with how do I see the sort of value-based care or delegated groups environment and data and efforts really reflected into the snapshot ultimately, and who's going to end up using this snapshot and find it helpful. And so can we all see ourselves in it, ultimately, because then people will use it. People will actually then turn to it as a source of information. And so I feel like that's sort of, we do need to set some foundational work. And maybe it is just getting information earlier, a week ahead before the next meeting or whatever it may be. But just to be able to bound, sort of, as Kevin said, what is our responsibility? What is the actual reach that this work group can really make, and recommendations that would be helpful, versus where we can also all be thinking pie in the sky of and so excited about trying to improve primary care in California. So that's really my comment. It's just I'm struggling with trying to figure out what are the boundaries within which I'm supposed to operate in terms of my thinking, as well as what is the data that then we're supposed to be looking at in order to inform this.
Thank you, Susan. That's super helpful input, and we will take that back and think about that, and also just welcome any recommendations that you all have for how we can, provide more information, foundational stuff to really define that scope and give you a chance to think about what you would recommend that we do or not do. So definitely heard loud and clear that giving materials more in advance will be helpful, and we will absolutely do that, but really invite other feedback for any specific things that would help you feel like your contributions are most meaningful. Yeah.
Yeah, thanks, Debbie. Mary Jo.
Thank you. I just wanted to follow up on a theme of comments that I've heard, which is sort of reaching a better understanding of what portion of the investment is reaching primary care providers in ways that I like to say feel tangible to them and their patients. And we see this as a concern across states. And I will share that I think attestations can help. I think, over the long term, perhaps some type of additional reporting could help. But I will say that in the short term, what has worked well for states is showing the data. Because as soon as you show the data in aggregate, people say, well, that's kind of interesting. I wonder where that went. I don't feel like it went to me. And then sort of phase 2 is showing it by provider organization. And you say, oh, that's sort of interesting. I see which organizations it went to. I see mine there. Don't feel like it went to me. And then you kind of start to have, at least in my experience, some really meaningful conversations about where did the money go? What was it used to support? There's also an excellent new piece that came out a few weeks ago that Dr. Grumbach and I and Jill Gagian and Margareta and others got to sort of watch evolve. The Primary Care Investment Guide that I can share a link to it in the chat that talks about what are some of the most useful ways to use new investment in ways that do feel tangible to providers and their patients. And so I think it's important for us to keep thinking about how we answer those questions, but just know that some of it will sort of evolve naturally as we put more data sort of out into the public sphere.
Yeah, thanks for that, Mary Jo. Lisa, sorry, I wasn't sure if I skipped you. Your hand is number 1.
Thanks. This is related to what Mary Jo was just saying, and Carlina raised it, and Kevin. I just want to make sure that we're all talking about resources for practices in the same way. And I wasn't sure if we were talking about, for example, if resources are going to a physician group, or if we're talking about an actual, that these increases are reflected in increased pay and reimbursement directly to primary care providers. And of course, there's a difference because there are many physicians and other providers who are salaried, and I know that makes it hard to measure, but I do think there's a difference there. And as we're discussing this, I just want to make sure that we're all talking about the same thing and that I'm understanding what that means. So that was my first question. And then the second question was also kind of a clarification, and this may be totally obvious to everybody else, but I want to make sure I have an understanding of who the target audience is, because I know the purpose states that it's engaged stakeholders. And does that mean consumers? Does that mean researchers? Does that mean those of us who really care about health policy? Is that policymakers? Is it a combination? And mostly, I think the distinction between is that are we trying to directly reach consumers so they can make decisions or know what's going on, or are we talking about a different audience?
Yeah, thanks, Lisa. In terms of the stakeholders, it's not quite focused on consumers. The main stakeholders would be like purchasers, payers, providers, policymakers, as you said, consumer advocates and researchers, primarily using the snapshot. But we also envision these stakeholders then using the snapshot to maybe make deliverables for consumers. But in terms of primary audiences, it's really those people who are more involved in the healthcare space and in policymaking and advocacy.
And Lisa, I'll just add that I think part of our rationale for not focusing on consumers as a main audience is that, we don't envision the level of granularity that a consumer might need to make decisions about like which primary care provider to choose in the network will be included in the snapshot. So this is more like an overall picture of, the key domains and the indicators, like where are we're trying to assess the overall health of the primary care system and sector in California rather than get to the detail of, is my primary care provider a high quality primary care provider? Do they provide advanced access? And so those, that level of detail will not be in the snapshot. So that's, in a sense why we aren't saying consumers are our key audience. Where, thinking about policymakers and, advocates and researchers are really the key audiences.
Yeah, that makes sense. And I do hope that organizations will utilize this information because I do think patients are an important audience here, maybe not directly, but to understand the importance of increasing primary care spend. It seems very wonky, but it does impact the way that people receive healthcare in California. So that makes perfect sense that might be the job of other stakeholders, the engaged stakeholders, to kind of translate that. And then the second part of the question was just what we're talking about when we talk about resources going directly to physician practices and how we're measuring that. Are we trying to look at, is it going to the primary care provider directly, or are we sort of stopping at the group level? And I just wanted to get a better sense of that.
Yeah, I can talk about that, I think, as similar to what Margareta mentioned earlier. So right now, at least for the OCA's data collection, we don't have visibility into the kind of provider organization or practice level investments. We see what the plans pay, but not what money goes to which provider organization. That's something that HCAI is interested in, and we've heard a lot as a key gap in our current available data is to really understand that funds flow all the way down to the practice level. So we welcome a conversation with this group about how HCAI might move in that direction, or others who are able to measure that. Really appreciate that. That's a big data gap at present.
And I know it's not reported, but I will just add that AAFP, for example, does an annual salary survey. And so there may be some, while it's, there are a lot of factors that go into a salary, it doesn't necessarily tie directly. It could be an interesting indicator of kind of market trends related to primary care spend requirements.
Yeah, thanks, Lisa. We will look into that survey as well, because we're always looking for other data sources to include to supplement what we're using in the snapshot. Yeah, Diana.
Hi, good morning, everyone. Thank you. Diana Douglas, Director of Policy with Health Access California, representing healthcare consumer advocacy for folks I haven't met. I think I have two questions or comments. My first is just looking at the outside of just the investment, looking across the 5 different domains that we have. I am interested in how this work group will be looking at those domains more holistically and related together. Hearing that if each time we meet, we're going to be looking at maybe 1 or 2 domains, but particularly looking at the investment domain. I mean, and I understand that this is a snapshot that is ultimately getting delivered, not necessarily a deep analytic work, but it's really the relationship between those domains that to me is painting a picture of how this is coming together to form the consumer experience and consumer quality. So looking at investment, but in sort of a box aside from quality and access in the other domains. I'm just curious, like, how we will bring those together. And then my second question, and maybe other folks know this or it's more obvious, but I was wondering, how are we accounting for some of, what I as a consumer, not a physician, see as like the ancillary sort of primary care services, talking about urgent cares and walk-in clinics and sort of these, other primary care settings where a lot of folks are accessing primary care that are often can maybe the first and most convenient way to access care, but from what I see are often there to sort of plug a hole in the primary care system as a whole, where you don't have access to a consistent primary care provider, or the wait times are too long, or it's not, convenient geographically. So I'm curious how we're treating, or how the snapshot will treat primary care in those settings, which I, see investment in just out in the world and in my neighborhood, but am not sure that those are always translating to the sort of continuity and quality of care that patients need to see.
Yeah, thank you for that question. I will start an answer and welcome others to add. In terms of your first question of looking across domains, I think one hope for the snapshot is that we will see trends over time and be able to look at there will be a concise enough set of indicators that we can trend things over time, looking at the different domains together in the snapshot and seeing how the trends in one, such as investment, perhaps not a causal relationship, but how they are associated with trends in the other domains. And definitely welcome other thoughts on how we can improve that sort of cross connections across the domains. And then in terms of urgent care settings, and I know we're running out of time, but I'll just say that the OCA primary care definition excludes urgent care as a setting that's included in our investment measurement for the reasons that you highlighted, that it's commonly used, but that probably reflects mostly a deficit in the more continuity-based primary care. So our investment measurement does not include spending for urgent care. We also will have in other domains some access measures, for example, from the CHIS survey, where people can say, do they have a usual source of care? And if so, is that a physician, or is that a urgent care or the emergency room? So there are other ways to get at a little bit how the urgent care and kind of retail clinic types of access are functioning. So I know we're over, and I want to respect everyone's time. I think we had one more question from Tiffany, and then we'll wrap up, and welcome further input over time. Go ahead, Tiffany.
Let me see if I can unmute. Oh. Okay, Tiffany, you should be able to unmute now.
Perfect. Thank you. I appreciate it. I apologize. I was just asking, and it might have been answered by one of the other questions. This snapshot did not necessarily include independent practices and virtual healthcare providers with respect to primary care? Is there a way of tapping into and understanding how many individuals are utilizing some of those virtual healthcare options to supplement or offset that primary care?
Yeah, that's a good question. There isn't really a diversity of what folks do to access services. So our investment measure does not measure that. And I'm not aware of a data source that could flesh out, in detail where people are going to all the different types of practices and other settings. So if there are existing data to help us know where the population is going for care, we're very interested in learning about those.
Well, I also think there might be an opportunity to curate that data, because I think as those options continue to grow and we continue to see shifts in coverage and access over the next couple of years, I think being informed, and whether it's through surveys, patient surveys, or a more comprehensive campaign and working with plans to get that data. And I, welcome opportunities to be a part and assist in any way that I can. I'm not in the clinician field, but coming from the patient advocacy, community health work, and community health perspective, I welcome opportunities to be able to gather that, because I think that's going to better inform trends and also help support the snapshot here, as well as when you think about greater things that impact access, accessibility, and all the things that go into what this snapshot may start to reflect.
Thank you so much for that input. We appreciate your interest in contributing to the work. And I will just wrap us up very quickly here, since we are a couple of minutes over time. Appreciate your patience. Let's see here. So this is our timeline for the next 12 months. We will be releasing the HCAI brief on the health of primary care in California later this month, and we'll send that along to you all when we have it. And then over the next 9 months, the work group will be focusing on developing the primary care indicators for the 2026 static report. And we'll continue our discussion of indicators in March. And then as our next step, we will ask work group members to respond to a post-meeting survey, giving feedback on whether the indicators meet the discussed evaluation criteria, the investment indicators we discussed today, and whether they should be included in the 2027 interactive snapshot dashboard. Also welcome other input you have on investment indicators we may not have discussed. And then please do send any feedback you have on the workgroup charter to Miranda by January 28th. At our March meeting, we'll continue reviewing indicators for the snapshot. So appreciate all of your participation today and look forward to continuing our conversation in March. Have a great day.